Happy Sunday to everyone across the time zones. Welcome to the live Q&A of Day 2 Conference, Session 3. Again, my name is Zoe, and I will be your moderator, reminding everyone that recordings will be posted on the CNET's website following the conference. We have a number of questions, which is great. However, some of the questions we will direct to the appropriate speaker at the Zoom with the experts, which is available after the conference closing remarks. You can come in and out of the Zoom rooms. In one room is the medical oncology and palliative care. In another room is surgery. And another room is medical oncology. And the other room is nuclear medicine and interventional radiology. We will start our first question to Dr. Beauregard. Do you know the status of Prrt in Manitoba?
Hi, everybody. Actually, no. I don't have any other information or where the approval for funding is at.
At Manitoba, yeah, it's not currently funded and available in Manitoba. For Dr. Rodriguez, I received my first AstraZeneca vaccine in March at the urging of the government. Shortly thereafter, the Ontario government advised that people with certain medical conditions should not wait 12 to 16 weeks for their second shot, but rather should get it at the manufacturing recommendation. I got it at 4 weeks. Now they're saying not earlier than 8 weeks. Did I get it too early? The messenger RNA is second, and she received the AstraZeneca.
No, I think she did the right approach, and the recommendation is for cancer patients that are on active treatment, such as chemotherapy or other treatments, they should receive the vaccination, the second dose within 3 or 4 weeks. So I think that she did the appropriate management.
Thank you. For Prrt trial in Quebec, is there a minimum grade or tumor size?
Short answer is no. We consider tumors from any grade, with, of course, knowing that the higher the grade is, or the Ki-67, the lower the likelihood of gallium scan positivity decreases. But no, we treated patients with Ki-67 well above 30 so far.
Thank you, Dr. Beauregard. Dr. Rodriguez, given the rapid development of vaccines using messenger RNA, do you see this as a method of treatment for NET cancer? Are there currently trials underway?
Yeah, I'm not aware of any specific trial using RNA technology for NETs. I know that there were some attempts for early phases clinical trials in other solid tumors, but I'm not aware of any specific trial for NETs.
Thank you. Dr. Cohen, for the trial you mentioned in Houston on PB212, was the tumor grade of the patients who participated disclosed?
It was not disclosed on their slides or website, but I do know if you go to the LAC Nets, which is the LA Nets group, you'll see that the doctor there is basically starting a new clinical trial. It's Dr. Delpassand in the next month or two. So I think the appropriate thing would be to contact him. It's Excel Diagnostics and Nuclear Oncology Center, and see what their criteria are for inclusion and exclusion.
About alpha therapy, I'm wondering if a Canadian patient can be referred to another country, such as Germany, Australia, and India. I am assuming this needs to be discussed with our oncologist. Dr. Cohen?
Yes, the answer is that you probably can be referred. Some of the Australian sites and some of the German sites were taking patients One of the pioneers in Germany was a physician named Richard Baum, and he was in a private clinic. He's moved to Frankfurt, so I'm not sure exactly what his situation is now. If he's at a university, it's probably going to be a little bit more restricted. There's a company, Genesis, that is involved in Australia that they could contact. I think a lot of these sites are willing to enroll patients in clinical trials. So in Australia and Germany, probably you can get into a clinical trial a lot more easily. And I would think that's the case in India.
Thank you, Dr. Cohen. Dr. Beauregard, what is the process for patients who don't qualify for Lutathera and wish to be referred to Quebec to participate in the personalized hospital-sponsored trial? And do you accept patients from across the country?
We do accept patients from across the country, and I think we have treated patients from the majority of the provinces in the last years. And the process is really to have the oncologist or surgeon or whatever the primary net doctor is to refer the case to us. And we'll guide them as to what documentation, what scans do we need on CD. And once we receive the materials, we do schedule a telephone consult with the patient, and we don't require to travel for consult, just for treatment. So we manage the rest by telephone.
Thank you so much. Dr. Hannon, thank you so much for mentioning and acknowledging Lynn Gates. She has been an incredible contributor to our community, and we too are so sorry that she cannot be with us this year. There's a question for you as well. What are your thoughts on CBD oil or marijuana for cancer pain?
What a great question. Thank you so much. I think it's something that more and more patients ask us about all the time. I'm sure my co-presenters also get asked about this from their patients. Certainly, some patients find they do get symptom relief, either for pain, but also for other symptoms like boosting their appetite, helping them to feel less stressed and anxious, and helping with sleep management. And there's usually no issue related to taking any of CBD products, but it's always worth just checking with your oncologist and your clinical team to make sure if you're on a clinical trial or you're taking specific treatments, that there's no reason why perhaps you should not be taking that. It doesn't usually replace the need to take other pain medications, but certainly from my perspective, many of my patients do use CBD, and they find that it can be helpful for several different symptoms.
Thank you. Dr. Cohen, what do you think is the likelihood of alpha therapy being available in Canada in the next 2 to 3 years?
I think it's extremely likely. There's a huge number of groups that are looking at this right now. One of the major limitations is the unavailability of actinium, and as a result, it's hard to get the clinical trials started. But I'm certain some of the other centers like Dr. Beauregard's and Quebec City are looking at this right now. And I can tell you the University of British Columbia, the Triumph Cyclotron group is planning a major facility to manufacture actinium-225.
Very nice. Thank you, Dr. Cohen. Dr. Beauregard, would a second course of Prrt be useful to treat the numerous NETs remaining after the first treatment cycle, the 4 treatments that now shows as viable?
Yes, in general, Prrt do works as a retreatment in the patients that it worked in the first place. Of course, if there was no tumor control whatsoever during the first course of 4 cycles, it's unlikely that further Prrt will benefit. So in those patients that did responded, whenever the tumor reprogresses or there's some new, whether it's new lesions or the same lesions reprogressing, we can retreat. Typically, we would give 2 additional cycles, a short course of 2 cycles, and we can repeat that as long as there are clinical benefits, which would not counterweight any increase in risk. So we always, for each individual patients, weight the benefits versus risk that's what guides us. And so far, we had a few patients having received a total of 8 cycles at our site.
Do you think there will be any new hospital-sponsored PRRT trials in the future beyond the 2 existing?
I don't know. To be honest, the fact that now Lutathera is a commercialized options that is readily available without having to set up a trial, I would think they would be, no, there might be some new, but unlikely to be many other trials, new trials, except for those groups that, like us, want to explore different ways of giving PRT, or of course, if some new radionuclides for PRT becomes available. But my expectation is that on the short term, there wouldn't be any trial.
Thank you. Maybe this is for Dr. Cohen. There seems to exist a kind of PRRT that is effective for tumor without somatostatin receptor. What is the situation about this?
Well, I'm not 100% certain what the questioner is asking, but he's certainly correct. There's a lot of targets that are showing up, and not just somatostatin. There's tremendous interest in something called FAPI, fibroblast activating protein inhibitor, that seems to be manufactured in a lot of advanced tumors, and there's real interest in labeling it with lutetium. It doesn't bind directly to the tumors, but it binds to the scar tissue around the tumors. There's other targets. There's the insulin growth factor, which I didn't mention, which is being used by fusion technologies currently. They're just doing safety at this point, but my guess is that there'll be other targets identified in cancer cells, and besides just somatostatin, and we'll have multiple targets that we're going to use chemotherapy and radiation therapy against.
Thank you, Dr. Cohen. Dr. Hannon, are we using cannabis and or psilocybin for NETs patients at any time during palliative care in Canada? If not, is it something that will be explored, especially for end-of-life NETs patients?
Another great question. So psilocybin is also something that's getting a lot of interest right now. And I know that there's a couple of trials about to start in Toronto and probably in other places around the country and internationally, looking at psilocybin and other similar agents to help people who might be dealing with anxiety, distress, or death-related anxiety at the end of their life. There's been a couple of really interesting studies from the US, not specifically for neuroendocrine tumors, but for patients with advanced cancer more specific, more broadly. And that showed some really interesting and sustained benefits in terms of mood and depression. We have a study going on right now looking at intranasal ketamine for depression, and we'll have some results on that soon. But yes, definitely that whole area is really interesting, really exciting, and some very positive preliminary results. So I think we'll see a lot more of that in the coming years.
Thank you. And another question for you. What point is best to incorporate palliative care? Is there such a thing as too early?
So I'm going to say no, never too early, because I think we work really closely with your oncologist and with the rest of your team, recognizing that everybody has their own strengths and their own skill set that they bring, and you really want the best team looking after you. So you've got your surgeon who's making decisions about surgery, you've got your interventional radiologists making decisions about their expertise, you've got your oncologist talking about targeted therapies and chemotherapies. And then our job is to help you feel as well as you can for as long as you can. So we're always very happy to meet with people early on. It's always lovely for us to meet with people and to get to know them and to get to know what's important for them and to help them every step along the way. So definitely never too early.
Thank you. I wonder if Dr. Rodriguez can answer this question related to early diagnosis. Should regular blood screening be performed during routine checkups, specifically looking for elevated levels of the hormones produced by NET plasms?
Yeah, I think this is I think this is standard, right, for workup of neuroendocrine tumors at presentation. Obviously, for those patients that present with with symptoms such as diarrhea or flaccine or other classic symptoms for carcinoid syndrome, they should for sure have the 5-HIAA levels measured, as well as other hormones, right?
Thank you so much. And I wonder if you can answer this one as well. Watch and wait versus injection. Does this mean some percentage of those who chose watch and wait had the same outcome as those who chose lanreotide? If so, what percentage is that?
Yeah, I think it's a difficult question in terms of what is the best. There's no specific randomized clinical trial comparing both approaches. And I think it's really important to understand tumor biology, which essentially means how fast we think the tumor can progress without any specific treatment intervention. But obviously, we also need to factor patient preference into the management, right? We need to educate them on any specific deviation from the standard of care that we think that can impact on the long-term outcomes. I think for those patients that are asymptomatic, that they don't have symptoms, and they're for neuroendocrine tumors with low grade and low Ki-67, at diagnosis is something that we can consider. For those that are symptomatic or have carcinoid symptoms or have more advanced disease or higher Ki-67, I think that is some sort of treatment intervention needs to be done.
Thank you so much. So the other questions are actually not, we don't have a speaker here, such as this SBRT will direct that to interventional radiology at Zoom with the expert. And for Dr. Pasica as well, in the room where she will be. And the peanut resection will redirect that to surgery. So I think that is the end of our live Q&A. We still have, although we still have 2 minutes. Since we don't have any pending questions right now, wondering if our speaker have any closing remarks. Dr. Cohen?
Just as I was thinking of things I should have just mentioned, there's a real interest in prostate cancer, which has been driving a lot of the alpha therapies and combining lutetium and actinium therapies together. So I think you're going to see a mixture of beta and alphas going forward. The other thing is that there's a number of PSMA targets that are inhibitors that seem to have higher tumor uptake. So there's a lot of research work coming out in the next probably 1 to 2 years.
Thank you so much, Dr. Cohen. Dr. Hannon?
I probably have too many things to say and would take up the entire 2 minutes. So I'm just going to say thank you again for the opportunity to present. I'm going to be available at the next session. And if anybody has any questions, please do pop by and ask them. I look forward to speaking with you. Thank you.
Thank you so much. Dr. Beauregard?
Yes, thank you for the opportunity to speak. And I would conclude saying that there has been, in terms of PRT access across Canada, a very long way that we have done, much improvement over the 10 last years. There's still some gaps and challenges, as I highlighted in my presentation, but all of this will likely improve in the near future. Thank you.
Thank you so much. Dr. Rodriguez?
Yeah, I would like to thank you for the invitation, and I'm looking forward to speaking with you the next session.
Thank you so much. So a reminder about the conference evaluation to start filling in